Good afternoon. Welcome to Asthma Grand Rounds. My name is Chris Fanton. It's my pleasure to welcome you both here in our Bornstein Amphitheater and those who are joining us by video conferencing or at their computer by webcasting. Thank you for joining us. I'd just like those in the audience, if you would, I'm just going to mention we do have evaluation forms. They're at the desk where you signed in. We'd love your feedback about the program, and here's your chance also to be part of our planning committee. So as we think about the Asthma Grand Rounds for 2013, 2014, we'd love your thoughts about the topics and speakers for the coming year. And today it's my great pleasure to introduce our speaker, Dale Umetsu. Professor Umetsu is a senior associate in immunology at Boston Children's Hospital. He is the Prince Turki Al Saud Professor of Pediatrics at Harvard Medical School, and he's here to talk to us today about the interaction between innate and adaptive immunity in the development of asthma. Thank you for joining us, Professor Umetsu.
Thank you very much, and good afternoon. I'd like to thank Chris for inviting me to this Partners Grand Rounds. It is indeed a pleasure and honor to be here. So what I'm going to talk about today is how innate lymphoid cells and viral infection shape immunity in the lungs, particularly in the context of asthma. Now, I'm sure all of you know, or most of you know, that asthma was first described about 4,000 years ago by the Egyptians. And since that time, over the years, a number of different therapies have been tried for asthma. But one of the most interesting ones that I have seen so far is this one that was just recently published in 2012, swallowing live fish as a cure for asthma. Now, I don't know about you, but I have not asked any of my patients to swallow live fish, even the most difficult ones with very severe asthma. But of course, what I do use is inhaled corticosteroids, which is the most common therapy for asthma, and which became popular maybe about 40 years ago when asthma was first considered to be an inflammatory disease of the airways. And clearly, the inflammation in asthma was first thought to be due to mast cells and allergen-specific IgE, along with eosinophils. So the corticosteroids were thought to be directed at this inflammatory response caused by mast cells and eosinophils. And then about 25 years ago, when allergen-specific Th2 cells were described, the usefulness of corticosteroids began to be more appreciated because these Th2 cells are exquisitely sensitive to corticosteroids. Now, Th2 cells, of course, have been shown to play an important pathogenic role in asthma because they secrete these Th2 cytokines. As you know, IL-4 is a switch factor for IgE. IL-5 enhances the growth and differentiation of eosinophils. And IL-13 directly causes airway hyperreactivity, a cardinal feature of asthma, by having direct effects on airway epithelial cells and airway smooth muscle cells. Now, although Th2 cells, eosinophils, and mast cells can explain many of the features of asthma, there are many observations in human asthma that cannot be explained by this Th2 paradigm. So, although these Th2 cells and eosinophils, as I mentioned, are sensitive to corticosteroids, the prevalence of asthma has actually increased dramatically over the past 30 years, despite an increase in the use of corticosteroids. In addition, these non-Th2 factors, gamma interferon, IL-17, and neutrophils, are frequently found in the lungs of patients, particularly in the lungs of patients with severe and corticosteroid-resistant asthma. Moreover, many other non-Th2 factors, such as viruses, air pollution, and exercise, cause asthma regardless of the presence of allergy. And also, most patients who are sensitized to allergens, that is, those who have hay fever or allergic rhinitis, do not develop asthma. And this suggests that these Th2 cells by themselves are really not sufficient for the development of asthma. And finally, Th2 targeted treatments, for example, with anti-IL-4, anti-IL-5, or IL-13 antagonists, have not really been as effective as hoped in many, although not all, clinical studies of asthma. And so, therefore, over the past 5 years, it has become quite clear that asthma is much more than Th2 cells and eosinophils, and that asthma is really a very heterogeneous and complex trait with at least several distinct phenotypes. So, for example, there's an allergen-induced or allergic asthma phenotype, which is associated with sensitization to a number of different allergens, including house dust mite, pollen, ragweed, cockroach, and so on. And this is associated with eosinophils in the airways and perhaps with adaptive immunity. There's also a non-allergen-induced or non-allergic phenotype associated with exposure to air pollution, including ozone, cigarette smoke, diesel particles, as well as with infection, and perhaps and associated with neutrophils in the airways and innate immunity, and perhaps and is also associated with resistance to corticosteroid therapy. There may also be an intrinsic form of asthma and perhaps other forms of asthma as well. Now, this is a very simplified version of the different phenotypes in asthma. This is a more sophisticated one done by Sally Wenzel, published earlier this year. And she calls this the Th2 and non-Th2 phenotypes. But you can see that in the Th2 phenotype, there's an allergen component. In the non-Th2 component, there's this late onset, obesity-associated, smoking-associated, and neutrophilic asthma. But what this heterogeneity indicates is that there must be other factors and components of immunity, in addition to Th2 cells, that must regulate and shape the development of asthma. So we need to understand these other pathways so we can develop better therapies for asthma, particularly for this non-Th2 phenotypes beyond corticosteroids and perhaps beyond swallowing live fish for asthma. So to help sort out these phenotypes and these pathways that lead to these phenotypes, a number of mouse models have been developed. Now, I just wanted to mention a few words about mouse models. Certainly mice are not humans, and so what we find in mice is not always applicable to humans. However, I should remind you that many of the foundations of immunology were first established in mice. So Th1 and Th2 cells were first described in mice by Bob Kaufman and Tim Mossman. Th17 cells, regulatory T cells, also first described in mice before in humans. Dendritic cells were described by Ralph Steinman in mice first, and of course he received the Nobel Prize earlier this year in medicine. Toll-like receptors also described first in mice before in humans, and Bruce Beutler received the Nobel Prize in medicine for that discovery. So I believe that these mouse models of asthma can be used to dissect this complex problem and to define many of the different pathways that can lead to asthma. And this is partly because mice do develop airway hyperreactivity and airway inflammation, which are key features in human asthma. Now, there are many different models of asthma in mice, and 3 of them are shown here on this slide. So there is this allergen-induced model in which mice are sensitized and then challenged with allergens. In this case, I guess we're hearing some of the other sites. So mice are sensitized and challenged with allergen, in this case ovalbumin, but any allergen can use dust mite, cockroach, or fungal antigens. And you can see that the mice develop severe airway hyperreactivity, shown by these blue symbols, as demonstrated by challenge of intubated and mechanically ventilated mice with increasing concentrations of methylcholine, which increases airway resistance, plotted here on the y-axis. Now, there are other models, in this case one associated with air pollution, where mice are repeatedly exposed to ozone, and the mice develop airway hyperreactivity, shown by those red symbols. Here is a model performed by Michael Holtzman's group at Washington University, a model of chronic asthma where mice are exposed to viruses, Sendai virus in this case, and the mice develop severe airway hyperreactivity. Now, these models of asthma show us a number of things. First, this shows that airway hyperreactivity can occur through a number of different pathways, some that require Th2 cells and adaptive immunity, for example, in this allergen-induced model. However, in the ozone model and the Sendai virus model, Th2 cells and adaptive immunity are not required, and the mice still get airway hyperreactivity. What these models also show is that natural killer T cells are required for all three of these models, and this can be seen, let's see, I have to go back here, can be seen in all three of these models, where if you take NKT cell deficient mice and sensitize them and challenge them with allergen, these mice fail to develop airway hyperreactivity. This is also seen in the ozone model. NKT cell deficient mice exposed to ozone fail to develop airway hyperreactivity, and also in the Sendai virus model, where the NKT cell deficient mice also fail to develop this airway hyperreactivity response. Now, I should point out that in all three of these models, a different subset of NKT cells are required. In the allergen model, NKT cells producing IL-4, IL-5, and IL-13 are required. In the ozone model, NKT cells producing IL-17 are required. And in the Sendai virus model, NKT cells producing IL-13 are required. So I won't have time to go into more of these studies with NKT cells because I'd like to talk more about another model of asthma that can help to further understand and explain the heterogeneity that we see in human asthma. Now, clearly, Th2 cells and adaptive immunity are very important for human asthma, at least some forms of asthma. But we also need to understand some of these non-allergic forms of asthma that involve innate immunity. So we wanted to understand an asthma phenotype, or at least a pathway, that was caused by viral infection. Now, as I'm sure all of you know, acute viral respiratory infections profoundly affect asthma. And as you know, in individuals with established asthma, most respiratory viral infections, for example, with rhinovirus or even influenza virus, trigger acute symptoms of asthma. And in many of these instances, the asthma is quite resistant to corticosteroid therapy. And as we learned in 2009, 2010, H1N1 pandemic influenza A virus infection caused particularly severe disease in patients with asthma. However, the specific pathological pathways that are triggered by influenza and that result in asthma are not fully understood. So we wanted to look at this problem and how influenza might activate innate immune pathways that affect asthma independent of Th2 cells. And so we examined the effects of influenza A virus by infecting mice and examining the mechanisms that directly lead to airway hyperreactivity. So the initial studies were relatively straightforward. We took wild-type BALB/c mice, which is often used in studies of asthma, and we infected them with this H3N1 strain of influenza, and we saw that within 5 days of infection, the mice developed severe airway hyperreactivity, shown by these red symbols. In contrast, the mock-infected mice had normal airway responses, shown by these open boxes. And in these mice that were infected with influenza, an inflammatory response developed in the airways, consisting of lots of macrophages, as seen in the bronchoalveolar lavage fluid. There were a large increase in neutrophils in the airways, as well as lymphocytes, but not eosinophils, a pattern that you might see in patients who are infected with influenza or other viruses. Now, this response that we saw with influenza was not strain-dependent, because we could infect another strain, C57 Black 6 mice, which tend to be more resistant to seeing asthma in these asthma models. But you can see that these mice, when infected, also developed severe airway hyperreactivity. And in the lungs of both the BALB/c mice and the C57 Black 6 mice, you can see on histological sections an inflammatory response, here consisting of neutrophils and lymphocytes in the peribronchial space. Now, even though eosinophils were not seen in the lungs of these infected mice, IL-13 was still required for this influenza-induced airway hyperreactivity response. And this can be seen if we infect the IL-13 knockout mice with influenza. These mice fail to develop airway hyperreactivity, indicating the requirement for IL-13, whereas in the control mice, you can see that they develop severe airway hyperreactivity on infection. Now, in the lungs of the infected mice, IL-13 protein was also found, and you can see this increases over time after infection and peaks on day 4 of infection, around the time when airway hyperreactivity also peaks. Now, because this response occurred fairly rapidly within 4 to 5 days of infection, and we know, we hypothesized that innate immune processes were involved, whereas in adaptive immune processes, that takes 10 to 14 days to develop. And so with 4 days, this more likely indicates innate processes. And this turned out to be true since we could infect RAG knockout mice, recombinase gene knockout mice, which lack B cells and T cells and adaptive immunity. And you can see that these mice, when infected with influenza, developed severe airway hyperreactivity, indicating that there was no need for T cells or B cells or adaptive immunity. So this indicated that this influenza-induced airway hyperreactivity response developed through innate immune pathways that did not require T cells, B cells, or even NKT cells, since these RAG knockout mice lack even NKT cells. And this lack of a need for NKT cells was seen in these studies where we took CD1D knockout mice, which lack NKT cells. These could be infected with influenza, and these mice still develop airway hyperreactivity, shown by those red symbols. And in the lungs of these NKT cell deficient mice infected with influenza, you can see that there was a very significant rise in the number of macrophages in the bowel fluid, neutrophils, as well as lymphocytes. So the next step was to understand what innate processes were involved in this influenza response. And we had been studying IL-33, which is an innate cytokine, which is a member of the IL-1 cytokine family. IL-33 turns out to be found in the lungs of patients with severe asthma. It's also been found in the blood of patients undergoing anaphylaxis, although this is somewhat controversial. It's produced by epithelial cells, macrophages, and also by mast cells, among other cells. And it binds to its receptor called ST2, which is expressed on mast cells, basophils, eosinophils, as well as Th2 cells. Now, very importantly, the genes for IL-33 and ST2 have been shown to be very important asthma susceptibility genes, as shown in a number of genome-wide association studies. And as we and others had found, a treatment of mice, even RAG knockout mice with recombinant IL-33, can induce airway hyperreactivity and the production of Th2 cytokines, IL-13 and IL-5, even in the absence of T cells. And that's shown on this slide, where we administered recombinant IL-33 to RAG knockout mice. And you can see that in these open circles, these mice develop significant airway hyperreactivity, not really different from the wild-type mice given IL-33.